Welcome back to Confused Neuron. Okay, today we are absolutely going to cure your pharmacology winter of despair. Seriously, we're going to cut through this massive pile of GI material like a hot knife through warm butter. So grab your mental dry erase markers and get focused, because we are hitting the whiteboard right now.
So, right off the bat, think about this. Your stomach is literally a muscular sac filled with highly corrosive hydrochloric acid. Why on earth doesn't it just digest itself? Well, usually it has a killer defense system. But what happens when those defenses completely fail? That's what this explainer is all about. Peptic ulcer disease. And more importantly for you, we're going to break down the exact pharmacology we use to stop it in its tracks before you fail your exam.
All right, here's our quick whiteboard battle plan for today. Number 1, the enemy. 2, the arsenal. 3, the gear. 4, the skull and stop sign warnings. And finally, number 5, our treatment battle plan. Let's get right into it.
Starting off with Section 1, the enemy, also known as the pathophysiology.
To really visualize what's happening in the GI tract, I want you to picture a house. I'm basically drawing one out here on the board. Peptic ulcer disease, or PUD, is essentially a faulty roof and acid rain situation. The acid rain is the excessive hydrochloric acid pouring down inside the stomach. And that faulty roof? That's your compromised mucosal defense. So you've got acid rain pouring down, your roof is full of holes, and as a result, the inside of your house, your delicate stomach mucosa, just gets completely wrecked.
Now, who exactly is punching all these holes in our roof? Take a look at this biopsy image I've got on the board. Kind of looks like a fuzzy jelly bean of doom, right? Well, that is Helicobacter pylori, a gram-negative bacteria. Infection with H. pylori, along with popping way too many NSAIDs, non-steroidal anti-inflammatory drugs, are the two absolute main causes of peptic ulcer disease. This fuzzy little jelly bean is our primary target today.
Moving right along to Section 2, the arsenal. Let's talk drug classes.
Now pay close attention here, because if you forget these on your test, I'm going to have to virtually smack your gluteus maximus. Go ahead and just screenshot this table right now. It is the ultimate cheat sheet. Notice the suffixes. They're a dead giveaway. Antimicrobials like amoxicillin. They hunt down and eradicate the bacteria. H2 blockers, which almost always end in titidine, like ranitidine, and our PPIs, which end in prizole, like omeprazole, they stop the acid rain. And finally, you've got mucosal protectants like sucralfate and bismuth subsalicylate. Think of them as the physical tar and shingles used to patch up that faulty roof.
Up next is Section 3, the gear. How do these drugs actually work?
Let's focus on the absolute heavy hitters here, the proton pump inhibitors, or PPIs. Understanding this mechanism shows exactly why they blow H2 blockers out of the water. Let me draw a massive star next to Step 1. For maximum effect, the patient absolutely must take their PPI 30 to 60 minutes before their largest meal. Why? Well, Step 2. Once it's absorbed, the drug travels to the stomach lining and forms a covalent bond to the H+, K+ ATPase enzyme. Guys, a covalent bond is practically permanent. Because of that, Step 3 is a massive, long duration of acid suppression. The drug itself might not stay in the bloodstream very long, but that acid pump? It's totally broken until the body builds a brand new one.
Let's look at Section 4, the skull and stop sign, which means we're talking warnings and side effects.
Look, every medication in the history of medicine has a dark side, right? Let's contrast two of our main players on the board. On the left, we've got our PPIs. Because they suppress acid so incredibly well for so long, they get the skull symbol for some pretty nasty side effects. For instance, your body actually needs acid to absorb vitamin B12. So, long-term PPI use, boom, B12 deficiency. It also alters your gut flora, which seriously spikes the risk for C. diff diarrhea. Now, look over on the right at sucralfate. This is our mucosal protectant that forms a physical, gel-like barrier over the ulcer. But here is the massive red stop sign. Sucralfate literally requires an acidic pH to activate. So the huge takeaway here is that you absolutely cannot administer it alongside PPIs or antacids, or it just won't work at all.
I actually want to stay on PPIs for just another second, because we need to rapid-fire some major skull and crossbones warnings the test makers absolutely love. If I circle this first bullet point, yeah, pay close attention to this one. It's a massive drug-drug interaction. Omeprazole actively inhibits the liver enzyme CYP2C19. Why does that matter? Because it completely prevents the blood thinner clopidogrel from converting into its active form.
it drastically decreases its efficacy, which is a huge danger to your patient. Also, prolonged use, or talking beyond a year, increases the risk of bone fractures. And lastly, keep an eye out for hypomagnesemia and a weirdly increased risk of getting pneumonia.
All right, Section 5. Time for the battle plan, our treatment algorithm.
Let's sketch out the absolute gold standard defense on the board here, bismuth quadruple therapy. We are hitting this bacteria from 4 completely different angles for 10 to 14 days. If you want a great mnemonic to remember the drugs, just write down, please make tummy better. That stands for a PPI, metronidazole, tetracycline, and bismuth subsalicylate. This combo gives you a 90% or greater eradication rate. And here is a huge clinical bonus. This is the perfect go-to regimen for patients who have a penicillin allergy.
Now, there is an alternative backup plan called triple therapy. This one uses a PPI, amoxicillin, and clarithromycin. But look at this huge underlined warning text I put at the bottom. You should only use this alternative if your local clarithromycin resistance is documented as low and the patient has 0 prior exposure to macrolide antibiotics. If they've ever had a macrolide before, don't risk it, just go straight back to the quadruple therapy.
As we start to wrap up this whiteboard explainer, I'm writing one last thing in giant, high-contrast letters right in the middle of the board. Are you ready? Do not mix your PPIs with clopidogrel. Seriously, it is a classic trap. Keeping this specific drug-drug interaction locked in your brain is not just going to save your pharmacology grade, it is literally going to save lives.
Actually, before you go, I want to leave you with one final, slightly provocative question. A minute ago, we learned that long-term PPI use increases the risk of bone fractures. That happens because the elevated gastric pH completely blocks the absorption of standard calcium carbonate. So, how exactly do we get these patients the calcium they desperately need to protect their bones? Think about it. The answer? You switch them over to calcium citrate. Why? Because the absorption of the citrate salt literally does not care about gastric pH. It works anyway. All right, that's it for today. Keep studying hard, and we'll see you in the next explainer.